Today our topic of discussion is cervical spine imaging. So specifically cervical spine imaging, per se imaging is anything which is pattern identification. We have to identify the pattern and we have to compare with the given x-ray. So what is the indication to do a cervical spine imaging in trauma? We have two criteria. One is the nexus criteria, another one is Canadian C spine rule. This is Canadian C spine rule. So the nexus criteria says whenever there is a focal neurological deficit or ethanol or intoxication, distracting injury other than the cervical spine injury, and unconsciousness or altered level of consciousness and midline spinal tenderness, any of these is present, any one, then we have to go ahead with the imaging of cervical spine. Coming to Canadian C-spine rule, it has a high risk factors. High risk factors are age more than 65 years, dangerous mechanism of injury, and parasitaceous of extremities. We have to directly go for a radiology. It can be either X-ray or CT or imaging of C-spine. CT imaging of C-spine. So what are the dangerous mechanisms of injury? Dangerous mechanisms of injury has been defined as fall from an elevation of more than 3 feet or 5 stairs and axial load on the head, example in case of diving and all, and motor vehicle collision of high speed. High speed is defined as more than 100 kilometers per hour. Either the vehicle is rolling over or ejection from the vehicle or motorized recreational vehicle accidents or bicycle struck on collision. That means a motor vehicle struck by a bicycle, then we have to take it as a dangerous mechanism of injury, and we have to follow up with follow and do an X-ray or a CT imaging of the C-spine. This is there, then we have to go ahead with the low risk factors. Low risk factors are either simple rear end motor vehicle collision or sitting position in the emergency department, ambulatory or any time, or delayed onset of neck pain and absence of midline C-spine tenderness. If these characteristics are not met, then we have to go for a radiology. If these characteristics are there, anytime sitting in the ED or delayed onset of neck pain, anything is there, then we have to go ahead and see the rotation of the neck. Either 45-degree rotation is possible by either side, we have to see. And if that is also able to do, then radiology is not required for the patient. What is simple rear end collision, by the way? The simple rear end collision, it excludes pushed into the incoming of the vehicle or intrusion and hit by the bus or large truck, rollover, or hit by a speed vehicle. See, these are not included in simple rear end collisions. So if these are the indications of taking a CT or X-ray or imaging per se in cervical spine injury. Common cervical X-ray views we have as one is the AP view, anteroposterior view, and one is lateral view, and the one is Simmer's view or the cervicothoracic view. This view is particularly used for visualizing the lower cervical spines like C5, C6, C7, and it extends even the T1 we can see properly, and it is taken by the X-rays projecting lateral aspect of the patient, and the hand is abducted and you can see the abducted humerus in the X-ray like this. And oblique view, another one is oblique view, which we use for visualizing the cervical intervertebral canal in the cervical X-ray. What is the sequence? What is the scientific sequence where we can read a cervical spine X-ray? It's the heights of the vertebral bones and the interspaces. We have to see the height of the bones. That's the first thing we have to see and compare. And bone density, we can see the bone density. The facets is Scotty dog, specifically not in the cervical spine X-ray, but still we can see the lamina and pedicle fracture if it is there, and neural foramina, as I told, mainly in the oblique view. We will be able to visualize the neuroforaminas and the alignments, facets, margins, spinous and transverse process. These are the spinous processes, these are the transverse process in the AP view. So regarding the radiological anatomy, so we will see the specific parts in the lateral view of X-ray. From the top we can see this sella turcica and the sphenoid sinus near to it. It is, as radiological, it is really near. We will be able to access intranasally for any surgery in the sella turcica. And the mastoidea cells is over here, and this is the occipital bone. Here we can see the spinous processes of all the vertebrae. It is specifically C1, C2, C3, C4, C5, C6, C7, and the C2 is the most prominent of the cervical vertebrae. This we can see the anterior arch of C1, anterior arch of C1. Here you can see the dens of the C2, and we can see the intervertebral foramina, pedicle. Here is a body, here is a pedicle, here is a pedicle, and this is the spinous processes. All this we can visualize in a lateral view. And coming to the soft tissues and other structures, we can see the mandible over here. Just below that, we'll be able to see the body of the hyoid bone and the air passage. We can see it very clearly over here. Here is the trachea. Here's the trachea. Okay, and you can see the sternum over here and the clavicle over here. Okay, these are the parts we can see in the lateral x-ray, and in the AP view as such. Here is the first rib. From below to up, here is the first rib, and this is trachea, which you can see the dark lines over here. And this is the uncovertebral articulation, the articulation between the vertebral bodies and articulations, and C2 vertebral body. You can see over here, C2 vertebral body, and the atlantoaxial joint over here. Atlantoaxial joint over here. So to see the atlantoaxial joint better, we have another view called as a peg view or the odontoid view. You'll be able to see here is the axis. Here is the axis, and these are the lateral masses of the atlas as well. So whenever we see a peg view, we will be able to differentiate between the transverse atlantal ligament tear or not, because transverse atlantal ligament is very important part of stabilizing the atlantoaxial joint. If transverse atlantal ligament is ruptured, it's the instability of atlantoaxial joints. So that we can find out in a X-ray of a peg view, which is an open mouth view. Inside the mouth, you'll be able to see the lateral masses of the C1 and the dens, and this is the C2 vertebra as well. So this is a peg view. You'll be able to see the lateral masses of the C1. Here is the dens, and this bone is C2 or the axis. So one method is lateral mass displacement of more than 8 mm is seen in 90% of the patients with transverse ligament injury. So this is, as we told, C1. So C1 lateral aspect, we are going to draw a line, vertical line. C1 lateral aspect, we are going to draw a vertical line. The tip of the C2, we are going to draw a line. And we are seeing the distance. In this end, there is more than 8 mm. So there is displacement of the lateral mass inside. So it denotes there is a C1 fracture, otherwise called as the Jefferson's fracture. Another method is C1-C2 ratio, which we can use to find out whether there is any transverse atlantal ligament injury or not. By this method, we are using that whether C1 by C2 ratio is more than 1.15, then it is 100% specific for transverse atlantal ligament injury. So we have to see the distance between the two C1 and the C2s, and then we'll make a ratio. We'll find a ratio C1 by C2, and if it is more than 1.15, then we are definite that there is going to be a TAL injury. Predental space, anterior arch. There is an anterior arch. Here is a dens. Here is a dens of the C2. This is C2, this is a dens of C2. And the distance between these two is going to be more than 3 mm. And then there is a fracture of C1. There is fracture of the C2 is there or not, we can find out by tracing the C2. See, the C2 can be traced over here. This is the C2, this is the spinous process of the C2. And here we come, this is the dens. If you can see, the dens is not vertical, it has fractured and has gone in a different direction. Here there is a fracture of the dens. If you follow up with the CT of this patient, the same patient, see the CT has also shown the dens fracture. There's 3 kinds of fracture in dens, and the treatment of the dens fracture is as screw fixation. Now we'll look at the subluxation and dislocations. We should see 4 lines in the CT. Four lines. They are curvilinear lines, but they are not interrupted lines. Uninterrupted curvilinear lines. One is an anterior vertebral line. Next is a posterior vertebral line through the posterior aspect of the body. And one is the spinolaminar line between the spine and the lamina. Between the spine and the lamina. At the beginning of the spines, we are able to draw this line. And the posterior spinous line connecting the tip of all the spinous processes of the cervical vertebra. If these lines are uninterrupted, then there is going to be no subluxation or dislocation. If there is any interruption, then we have to suspect a subluxation or dislocation. Talking about that, there is something called a pseudosubluxation. Pseudosubluxation. How this pseudosubluxation happens in case of children up to 8 years of age, there can be a lative translation or typically between the C2 and C3. If we calculate, if we see, we are going to feel like the C2 is subluxated over the C3, but in actual case it is not. If you are able to see, if you can see a small bulge of C2 in front of C3, a small bulge, you'll be able to see. How to identify between a pseudosubluxation versus a real subluxation is by something called as a Schweizer's line. So this line is drawn between the anterior aspect of the posterior arch of C1 and anterior aspect of the posterior arch of C3. If you see, this is the posterior arch. These are the posterior arches, and in the anterior aspect of those, I am trying to connect between the C1 and C3. And if I am getting the anterior aspect, anteriormost part of the spinous process of C2 is more than 2 mm away from it, then it is going to be an actual dislocation. The anterior vertebral line, we'll be able to see that there is going to be a dislocation of this vertebra. Okay, so what is this going to be? C1, C2, C3, C4, C5. So there is C4, C5 subluxation. If you see, it is less than 50% of the surface which is subluxated. So it is not a dislocation, it is a subluxation. So when there is subluxation more than 50%, then it is called as dislocation. Dislocation, if you see in this anterior spinal line, if you see it over here, it is not at all touching the other parts, other two vertebra. If you see, there is more than 50% of it, it's displaced. So it is displacement, not a subluxation. And here if you see, if you draw the line, the posterior line also, if you draw, it is not in line with this vertebra. So which vertebra is it? 1, 2, 3, 4, 5 and 6. So C5, C6 less than 50%, so subluxation. If you see the fractures, there's going to be a wedge compression fracture over here. Wedge compression fracture. Anterior part is less than 75% of the posterior part, so it is going to be a wedge compression, and the fragment is also separated. Okay, here if you see, I'll be able to see that here there is going to be a burst fracture. It is not specifically compressed, but it is burst into different parts. So it is going to be a burst fracture of 1, 2, 3, 4, 5, 6, 7. C7 burst fracture. Okay, again if you move down here, this arrow marked as a chip fracture over here. This is a fracture of the body over here. Okay, here again if you know the hangman's fracture, C6 spinous process fracture, spinous process. You see the spinous process over here, that is fracture. You see in this, there are some old age changes also in this called as osteophytes. This over here, but the height of this vertebra is significantly reduced. There can be a compression fracture also. Okay, don't get confused that these are the bone chips. These are nothing but osteophytes. So this kid has presented to us with the onset of breathlessness, sudden onset of breathlessness, and if we see, there's going to be a steeple sign. If we see the trachea over here. So laryngotracheo bronchitis or croup is going to be the diagnosis if you see such a X-ray, such a trachea. Okay, and you can see something over here which is inside the spinal canal, and it's the same as density as that of the bone, so it is a intracanalicular calcification. If you see, particularly the bony lines are normal, but if you see the soft tissue, this is widened. The retropharyngeal space is widened, so it indicates retropharyngeal abscess. How to diagnose a retropharyngeal abscess from a X-ray? If you see at the C2 level, if the soft tissue at the level of C2 vertebra is more than 2 times of the width of the C2 vertebral body, then it's going to be retropharyngeal abscess. And if you see at the level of C4 vertebra, soft tissue width is going to be more than half of the C4 vertebral width, then it is going to be retropharyngeal abscess. Thank you.